breasts. And that's because back in 2015, when I was at RSNA, that was kind of the hot topic, and I just kind of wanted to see what had changed in the literature since that time. So it's going to be a review of the evidence and of the available modalities for supplemental screening. So the objectives today are first to just briefly review the background and evidence for breast cancer screening in general and current screening recommendations. Then to review the evidence for supplemental screening in women with dense breast tissue. Then just an overview and the evidence for supplemental screening modalities, which include ultrasound, MRI, and tomo. And then just a little bit of discussion and maybe some future directions. So first off, breast cancer screening. So the goals of screening tests in general are to detect disease early before it clinically manifests. The test should be affordable, it should be accessible to the general population, it should be acceptable to patients. We want it to be accurate, and the test needs to be held accountable for its successes and failures. And screening is, of course, only effective if the earlier treatment that results from detection of earlier disease is effective. So just quickly, a review of some of the parameters that we'll be looking at today. Sensitivity is, of course, the percentage of patients with the disease who receive a positive result. The specificity is the percentage of patients without the disease who receive a negative result. Our positive predictive value is the percentage of patients with a positive test who do have the disease, and the negative predictive value is the percentage of patients with a negative test who do not have the disease. And just remember that only the positive predictive value and the negative predictive value take into account the relative numbers of patients with and without disease. So false positives in screening, recalls for further imaging and testing are very common in screening mammography because we're trying to maximize our sensitivity, which comes at the cost of specificity. False positives do add anxiety and costs, and the consequences can range anywhere from added imaging to unnecessary surgery, which has significant morbidity. Goals for any screening program include both reducing the number of false positives, but also reducing the harm resulting from false positives. And that is why abnormalities on screening tests are worked up before we proceed to treatment. Falling sort of between categories on this chart is one particular issue which I haven't really seen referenced in other screening tests, which is that of overdiagnosis. So overdiagnosis refers to breast cancer which would not have caused clinical consequences in the patient's lifetime if it had not been detected. There are several studies that suggest that many cancers, especially in cases of a DCIS, are biologically insignificant and would never have become clinically apparent. And estimates of how many of these are out there is anywhere from 10 to 30% of diagnosed breast cancers. At this point, with what we know, it's impossible to distinguish which cancers were biologically significant from which ones were insignificant. So these patients will receive local and systemic therapy and never know that they could have gone their whole lives without ever being diagnosed. In short, then, overdiagnosis leads to overtreatment. So the mammography unit, it's been around since the 1960s, uses low-energy X-rays, and our images are obtained in compression with standard MLO and CC views. This is the best studied breast cancer screening modality, and it's the only modality with demonstrated mortality benefit. Breast cancer is the most common non-skin cancer in women, and it's the second deadliest cancer after lung cancer. In Canada, we estimate 25,000 new breast cancer diagnoses per year and 5,000 deaths, with around 9 times that number in the United States, and 1.8 million new diagnoses and over 460,000 deaths worldwide per year. The incidence of breast cancer actually increased significantly in developed countries, including the US and Canada, in the 1980s, stabilized after 2000, and has recently been declining slightly. It's unclear why this happened. There's a question if there has been a role for screening. Mammography screening did increase over this same time period, from only around 30% in the mid-1980s to about 70% uptake in 2008. In favor of this is the fact that the increase in incidence was mostly in situ and early stage cancers, which are what we're targeting with mammography. But going against this is the fact that we did not see a subsequent decline until only recently. There's been a question if this was related to postmenopausal hormone therapy. In favor of this is just before the decline in incidence, the Women's Health Initiative study came out, which led to a reduction in postmenopausal hormone therapy. And there has been a decline in estrogen receptor positive tumors since that time. There's also a question of whether other environmental factors might be in play, including lifetime estrogen exposure increases. Now, the mortality rates in the United States and Canada, conversely, have been declining since 1990, and that's attributed to both improvements in treatment and the detection of early cancers by screening. It's hard to tease apart what is related to what, however. There's multiple statistical models out there, and of course, they give a very wide range of results. Overall, the suggestion has been that divide in causation is around 50-50, and currently mortality rates are only around a third of what they were in the 1980s. In terms of the evidence for and against mammography, there have been multiple large prospective randomized control trials, which is really the standard of evidence, and they've been conducted in countries including Canada, the United States, the UK, and Sweden. And the most commonly quoted figure from analysis of these studies is that screening mammography reduces the odds of dying from breast cancer by around 20%. There's some question that this number might actually be higher. A large number of the patients in these trials ended up crossing over into screening arms, which can mask effect size. And our mammographic technology has improved significantly since the time of these trials, which should mean more cases of cancer identified earlier. There's also people, though, who think that the number is actually lower. For example, the newer treatments that we have are more effective, which may decrease the importance of very early diagnosis. And there's some statistical models suggesting that mortality reduction is as low as 2 to 10%. This is kind of the meta-analysis that gave us our 20% reduction. You can see by combining the results of all these trials, we get the 0.8 relative risk. But if you look closely at this, you see a few outliers, and that is both of the Canadian studies, where you can see this is much closer to a no reduction in relative risk than some of the other trials. So the question then is, what happened in Canada? What was different about this trial that led to these differences in results? So in Canada, our trial was initiated after the development of adjuvant therapy, which is in contrast to some of the earlier trials, including the landmark New York trial. And our control arm included systematic clinical breast examination. So that was a thorough 5 to 10 minute examination by a trained nurse practitioner, which is not the typical clinical practice. So that may have led to increased detection in the control arm. Our 25-year follow-up data found no mortality benefit to screening mammography, and it estimated that we're actually overdiagnosing about 22% of our screen-detected invasive cancers. So that's 1 for every 424 women who are screened. So these findings are concerning, but as I mentioned, there are a few things that may account for them, so we need to take these findings in context of both other trials and of the differences in the control group. And we need to remember that this trial preceded our recent improvements in screening technology. So in deciding who to screen, the patients in whom screening is of greatest value are those who are more likely to develop breast cancer. So patients who don't have other significant risk factors, such as BRCA mutations, they have a low incidence of breast cancer before 40, which rises up to 45, rises more steeply up to 65, and then plateaus. Baseline average lifetime risk for women without significant other risk factors is around 10 to 15%. We also want to screen patients who are more likely to benefit from early detection and treatment. So patients who have multiple comorbidities and are older will likely have a decrease in potential years of life gained, and that may contraindicate effective treatment. In deciding when to start screening, under 40 years, there's very low incidence of disease and there's very little evidence for screening. There's no randomized control trials, but a review of over 70,000 screening mammograms in women of 35 to 39 showed they had very high recall rates of almost 13%, and the positive predictive value of being recalled was only 1.3%. Between 40 and 49, we've got conflicting evidence, which leads to some variability in recommendations. There's fewer lives saved in this population due to decreased incidence and decreased sensitivity and specificity of screening mammography in this population. But because they're younger, there are more potential years of life saved. So one recent meta-analysis of the available trials found there's a non-significant trend of a relative reduction in mortality for these women, but it did not impact risk of advanced breast cancer, and again, this was non-significant. This trial also estimated that it would cost over $100,000 per year of life saved, which is above generally accepted limits. Between ages 50 and 70, this is where we have the strongest evidence of mortality reduction, with the caveats already described. So over 10 years, screening 10,000 women should prevent 8 deaths between ages 50 and 59, and 21 deaths between ages 60 and 69. And this is a much more affordable $21,000 per year of life saved. When it comes to when to stop screening, there's also variability in recommendations. We don't have very much data available for screening in women over 75. These patients may end up with lower stage cancer diagnoses at that point when their life expectancy is less than 10 years, so we wouldn't necessarily expect a decrease in mortality. There is an increased incidence of DCIS in this population, and again, without clear evidence for mortality benefit to treating their DCIS. And basically, this is a population where you have very high rates of overdiagnosis. Deciding how often to screen, it's difficult to say. There are some randomized control trials showing that screening every 2 to 3 years does effectively reduce mortality. And again, modeling studies show similar benefits to annual or biennial screening. There is, however, some limited evidence for earlier stage diagnosis with annual screening in women ages 40 to 49 who have dense breasts, and in postmenopausal women using hormone therapy. And again, of course, no evidence of mortality benefit for annual screening in these patients, and there were increased false positives and negative biopsies. So just then comparing from modeling studies, just what would we expect with more aggressive and less aggressive screening. So sort of the most aggressive option of annual screening women from 40 to 74, we would expect to save up to almost 11 lives, but as you can see, there's a large number of false positive mammograms and unnecessary biopsies. Whereas if we go with a much more conservative approach, screening women only from 50 to 69 on a biennial basis, we would expect only about half the number of lives saved, but much more significant reductions in false positives and unnecessary biopsies. So kind of a blend between the two is where most people are headed, and that makes sense. For women who are at average risk of breast cancer, it's been advised that screening should be performed with mammography since it's well studied. ACR recommends annual screening for women 40 to 69. It's a little more aggressive. The Canadian Task Force recommends screening every 2 to 3 years for women ages 50 to 74 and recommends against screening women under 50. The U.S. Preventative Services Task Force controversially also recommended biennial screening for women 50 to 74, but they're a little softer on women 40 to 49, saying it should be an individualized decision between the woman and her healthcare provider. It's a little harder to know what to do with women who are at increased risk of breast cancer. So those risk factors include increasing age, genetic predispositions, estrogen exposures, previous benign biopsies, and dense breasts. Now, in some cases, we have guidelines. So in case of genetic predisposition, there are risk assessment tools available for patients. And although there's no randomized control trials, there is some evidence on a case control basis that there may be protective benefits for younger women, 40 to 49, screened with mammography. There are many guidelines recommending MRI for women with greater than a 20% lifetime risk, but we don't have any data actually demonstrating a mortality reduction. In other cases, such as with dense breasts, it's a little less clear what to recommend. So that's kind of what I want to get into is what are the challenges in screening dense breasts? So mammographic breast density is the amount of radiopaque elements, which include skin, blood vessels, ductal and stromal glandular elements, and that's relative to radiolucent fat. Increased breast density may obscure both benign and malignant masses, and it does not correlate with physical exam findings or breast size. Classifying breast density, currently the 5th edition of BI-RADS classifies breast tissue as either almost entirely fatty, containing scattered areas of fibroglandular density, heterogeneously dense, which may obscure small masses, or extremely dense, lowering the sensitivity of mammography. This is based on any patch of dense tissue and is part of the routine report sent to referring physicians in the United States and commonly included in Canada. So these are just examples of each of the 4 categories. So predominantly fatty, scattered fibroglandular densities, heterogeneously dense, and extremely dense. And around 10% of women will be classified as extremely dense. So dense breasts as a term is usually used to refer to both heterogeneously dense and extremely dense breasts, and that accounts for almost 50% of women in the screening population. There are some limitations to assessing breast density. Breast density varies with age. It's most commonly seen under age 50, but it can be seen in up to 36% of women in their 70s. It also varies with parity, use of estrogen, tamoxifen, body habitus, and the phase of the menstrual cycle. Classification is also extremely operator dependent. One review of over 200,000 screening studies from 30 facilities in the United States, which had a little less than 50% of mammograms rated as dense, 37%, found a very wide range of variation across radiologists, and actually 17% of the mammograms had discordant assessments of dense versus non-dense on follow-up mammogram, which is concerning if we're going to start screening women differently based on which category they fall into. Computer-based breast density assessment is an area kind of under development. Given variability in radiologist assessment, it might be an area where computer quantification could have a role. Early systems were just based on mammographic images, but we've got newer methods which account for factors like breast compression. Now, these are not currently widely adopted and are mostly used for research purposes, and I don't know that that's likely to change in the immediate future. When it comes to screening dense breasts, the sensitivity of mammography is inversely correlated with breast density, and it can be as low as 68% in extremely dense breasts. So accurate reporting of breast density is important to communicate the level of sensitivity of the screening exam. Increased breast density is also an independent risk factor for breast cancer. This makes sense since most cancers develop in the radiopaque glandular parenchyma. The relative risk has not been well established. It's been estimated at anywhere from 1.2 times the relative risk for heterogeneously dense breasts and 2.2 times the relative risk for extremely dense breasts, anywhere up to 6 times relative risk. Now those more concerning studies have been criticized for only including the densest 10% of breasts, but that is how many women are currently classified as extremely dense. Dense breasts may not be as significant a risk factor for women who are already at very high risk. There was no additive risk identified in one cohort study of very high-risk women. And it may not be as applicable to non-Caucasian women. Black women, for example, have a higher likelihood of having fatty breasts, but a higher risk for aggressive breast cancers. And Asian women have a higher likelihood of having dense breasts, but a lower incidence of breast cancer. So just to kind of compare breast density with other risk factors for breast cancer, as you can see, it's a very wide range, which could put the relative risk anywhere from comparable to BRCA mutations to as high as atypical hyperplasia on biopsy, or as low as a strong alcohol history. So the big question, of course, we could talk about relative risk of developing breast cancer, but what about mortality? And the only really good study I could find looking at mortality, high mammographic density was not associated with an increased risk of death from breast cancer or with all-cause mortality. And that was in a 10-year follow-up of over 9,000 women diagnosed with invasive breast cancer. And as you can see, this is not just related to the size of the study population. The hazard ratio was actually lower. So this leads us to the question of what to do with dense breasts. I think given the fact that we do know that women are at increased risk of developing breast cancer if they have dense breasts, and sensitivity of current screening modalities is decreased in these patients, it's reasonable to at least consider whether additional tests could have additive benefit. That being said, this would be an enormous undertaking given that nearly 50% of women in the screening population fall into the category of dense breasts. And additional screening would mean more false positives in addition to more true positives, which puts an additional burden on the system and on patients. It may not actually be necessary given that there's no evidence of increased mortality from breast cancer. And age remains a more significant risk factor than breast density, but we don't offer supplemental screening to women with increasing age. So basically, in short, I think all of this together suggests that more evidence is necessary before we develop any guidelines for supplemental screening. And that goes along with several task forces and what they say. So there's no major guidelines advising breast density alone be used to determine the need for additional screening. The US task force found insufficient evidence to assess the balance of benefits and harms. And the Canadian task force said basically that although the idea of stratifying women by breast density is appealing, there's really not enough evidence. Now, in spite of this, in the United States, the question of how to screen these women has been forced into the spotlight, and that's because of dense breast legislation. So these are laws that require patients be informed of their breast density, the fact that dense breast tissue may interfere with cancer detection, and that dense breast tissue may be a risk factor for breast cancer. And some of these laws also require that patients be informed that they should speak to their physician about supplemental screening options. So this is 27 states currently. There's other states that have legislation on the table. And there was a national bill that was first introduced almost 6 years ago and has been reintroduced multiple times since. If enacted, that could affect up to 20 million American women. Now, counter to this, only 5 states mandate insurance coverage for supplemental screening in these patients. So this is just an example of the required statement. Many of these required statements are found to be not congruent with estimated literacy levels in the states in which they're sent out. So although this is a fairly clear statement for us, perhaps, stating that dense breast tissue is relatively common, it may make it more difficult to detect abnormalities, but they just want to raise awareness, and you can talk to your physician. But as you can see, someone who's not comfortable with medical terminology, the medical system, or is not comfortable in general with, dense information letters, might have a lot of trouble with this and might not know how to take it. This is just a map showing the states currently affected by dense breast legislation, and as you can see, there are far fewer black stars where insurance mandates coverage for these women for additional screening compared to the number of women being informed that they should potentially seek additional screening. So if we are going to screen women with dense breasts, what should we use? So what about clinical breast exam? The American Cancer Society has actually recently revised its guidelines and recommends against clinical breast examination. That's due to a lack of evidence for improved outcomes and to a very high false positive rate. Canadian Task Force also recommends against clinical breast examination. And even the World Health Organization indicates that clinical breast examination is only appropriate screening for women in low-resource settings. The issue with clinical breast exam is a lack of standardization, and it's actually been shown that when it's performed by trained nurses, clinical breast exam plus mammography has a greater sensitivity than mammography alone. But of course, with that comes a higher false positive rate. And unfortunately, in community practice, sensitivity is not as good. Breast self-examination is also currently not recommended by the Canadian Task Force. There's been no evidence of a reduction in mortality, and there is evidence of increased harm from false positives. So the trend now is to educate women about breast health, to encourage the more fuzzy term breast awareness, and to make sure that they do seek medical attention if concerning abnormalities such as discharge present. Screening with film versus digital mammography, there are differences. Digital mammography is more sensitive than film mammography for dense breasts. There's comparable sensitivity in fatty or scattered fibroglandular breasts, but particularly in extremely dense breasts, we go from a sensitivity around 68%, anywhere from 82 to 84%. And as with all other cases where we increase sensitivity, the false positive rate is also increased in younger women and women with dense breasts with digital mammography. The point may be moot, though, because currently 95% of FDA-accredited mammography units are digital. Digital is where we are headed, and that is what we are using here currently. It's just good to be aware of what the changes that result from that are. This is just the same breast imaged with digital and film mammography. And as you can see, there is the ability to have some improved resolution in this heterogeneously dense breast, and we can see skin much better. That being said, there are other options. Digital breast tomosynthesis, or TOMO, also called 3D mammogram, is a series of low-dose mammograms that we acquire at multiple angles through the breast, then reconstruct into thin slices in the same plane as a mammogram. If we acquire these separately, it does double the radiation exposure for the patient, although that remains below FDA radiation dose limits. But there is newer software out there that allows us to reconstruct the 2D image from the 3D dataset with comparable interpretability. Now, there are no RCTs comparing TOMO and mammography, and there's no good mortality data, but what we do have is promising. There's some prospective observational data showing increased sensitivity, detecting an additional 5 to 6 cases per 1,000 screens in women over 50. And in one self-referred group of asymptomatic women, we identified an additional 4 cancers per 1,000 screened, the majority of which were invasive cancers. This study is, of course, limited because there was no control group, and we don't know the risk profile of these self-referred women. The greatest impact of TOMO may actually be in reducing false positives, although there's mixed evidence when it's used for screening. There's a trial called the STORM 2 trial, which actually found increased false positive rates in women with dense breasts, very slightly increased, 5% versus 4%. Now, in this trial, all these studies were double read, and the patient was recalled if it was recommended by either reader. Conversely, on a review of 3 trials where the studies were single read, there were actually 16 fewer false positive findings per 1,000 women screened. Overall, TOMO is estimated to lead to, for every quality adjusted life year, cost about $50,000, which is better than some of the other modalities that we'll get to. There's some thought that this might be even better in the dense breast population where sensitivity requires a little bit more help, but we have less data available. So TOMO is increasingly available in the United States, and some sets of guidelines even are being updated to suggest women of average risk should at least consider annual TOMO screening. But it's only available in about 25% of American facilities, and it's not universally covered by insurance providers. And in Manitoba, it's not covered despite machine capabilities. So this is just showing a few cases. So this is a woman with a palpable abnormality indicated by the BB. Some calcifications indicated here. And on routine and compression views, it's hard to really see what might be accounting for this abnormality. But when we look at TOMO and can look at thin slices through this dense region, we can actually see an area of architectural distortion, which would not have been identifiable on the mammogram. Even in the case of calcifications, which we see here, we can see the fine linear pleomorphic nature of these calcifications much better with magnification views, and TOMO will not replace that. But we can see better the linear distribution concerning for ductal calcifications when we break it down into the thin slices of TOMO. This is just another case showing how it can be helpful to rule out abnormalities. There's concern for architectural distortion in this area of this heterogeneously dense breast, which can be better seen to relate to an oil cyst on TOMO. Another modality under investigation is screening whole breast ultrasound. This is much different from the targeted ultrasound that we use in the workup of abnormalities, and there's two forms that have been investigated. You can either use handheld ultrasound, either by technologists or radiologists, which can be inefficient and very difficult to standardize, or you can do automated breast ultrasound, which requires specialized equipment, but limited data does suggest that it's comparable in sensitivity and false positive rate to handheld screening. Both of these involve just systematic orthogonal scanning of the entire breast. And this is from a vendor website, but as you can see, this is sort of the type of equipment that is used for the automated cases. Unlike tomo, which you can perform at the same time as mammography, screening ultrasound requires a separate examination. There's no randomized control trials comparing mammography and whole breast ultrasound with mammography alone. And the available reviews generally agree that adding whole breast ultrasound slightly increases cancer detection and decreases cancer mortality, but greatly increases false positives and is probably not cost effective. So you'd have to screen around 2,800 women over a 25-year period to prevent one cancer-related death, which would cost over $100,000 per quality adjusted life year, above our typically accepted limits. It would lead to an estimated additional 980 biopsies, which would be a huge burden on the system. The positive predictive value of screening whole breast ultrasound has been estimated at only 3 to 8%, with recall rates as high as 15%. So in spite of this, the ACR guidelines do state that the addition of ultrasound to screening mammography may be useful for incremental cancer detection, but that it is within acceptable standard of care not to offer ultrasound screening. This is just an example of the type of images that you can get from these. You can do reconstruction, 3D, and change your views, but you can see it's a very large data set. Screening MRI has also been investigated, and as with all these modalities, it should be used in conjunction with mammography and restricted to women at increased risk of breast cancer. Right now, the American Cancer Society indicates there's insufficient evidence to recommend for or against MRI screening in heterogeneous or extremely dense breasts, which is actually their same category of recommendation as in women with a personal history of breast cancer. A systematic review of screening MRI after negative mammogram in women with dense breasts estimated a very high sensitivity and a good specificity, but there's a very wide range of positive predictive value estimates from as low as 3% up to 33%. And the recall rates are even higher than with screening ultrasound, up to 25%. And many of these abnormalities identified on screening MRI may need to be biopsied under MRI if no ultrasound correlate is identified. So additional cancers are identified, but due to the sample sizes, which are small in these studies, the number of additional cancers detected is very hard to estimate precisely. It could be anywhere from 3 to 29 additional cancers per 1,000 examinations. And there's no data on mortality benefit. Now, in spite of this, currently there's an international trial underway for screening MRI in dense breasts, the DENSE trial, which will be recruiting patients through 2019. So it'll be a while before we see what the results of that are. Regardless, screening MRI is a very high cost to the system, both financially and in terms of magnet time, and it does require IV contrast. So this is just an example of a woman with relatively dense breasts and of a small cancer on the subtraction MIP images, which was not identifiable on mammography. This is just showing an example of MRI in a woman with extremely dense breasts. And of course, MRI does allow us to use techniques such as kinetic assessment of enhancement. However, again, there's mixed evidence on the benefit of that. So there's also been a lot of work looking into a way to make an abbreviated protocol to screen with MRI. So there's been smaller trials looking at shorter protocols. Some use IV contrast, some don't. One study that was done in Germany I thought was interesting used an abbreviated protocol of just 1 pre-contrast and 1 early post-contrast acquisition. The acquisition time was only 3 minutes compared to 20 to 50 minutes for a full. And average expert reading time was just over 30 seconds. They found equivalent sensitivity and specificity to a full MRI, but this was relative to the full protocol, not based on follow-up. So it's hard to say if that's actually as good as it seems. This is just showing the images from this. So this is just the single pre-contrast image, the single post-contrast image, a subtraction image, and a subtraction MIP constructed from this data set. There are a few other modalities out there with less data, including contrast-enhanced spectral mammography, thermography, molecular breast imaging, and proteomics. So contrast-enhanced spectral mammography is interesting. It's a dual-energy contrast-enhanced mammography. Basically, the breast is exposed to low and high-energy X-ray beams in a single breast compression in MLO. They choose these to maximize and minimize the attenuation of breast relative to iodine. And then they will release the breast from compression, inject the contrast agent, and compress and re-image the breast after 3 minutes. These images we can then do subtraction on, which will cancel out the soft tissue contrast that's common to the two images, and isolate the iodine signal. And this is supposed to identify regions of angiogenesis. It's intended only as a problem-solving tool at this point, but early research does show increased diagnostic accuracy, and the standard reference test in this case was actually a combination of ultrasound and biopsy. This also has the advantage of being able to be added on to existing systems potentially. So with the caveat that this is a vendor image and therefore the best possible scenario, here's one with dense breasts, and on the subtraction image you can very clearly see a large cancer, which was occult on the original images. I doubt very much that this is completely representative, but it's certainly interesting. Thermography is a modality which was investigated in the 1970s. It was based on the observation that skin temperatures are elevated over breast cancers due to angiogenesis and increased flow. And there is an FDA-approved device out there, but it's approved based on safety, not on efficacy. It's got very poor test characteristics, a false negative rate as high as 60% and very low specificity. It's not recommended by any major organization. And unfortunately, in spite of this, it's available both in Canada and the United States from private clinics, and it's appealing to many women because there's no need for compression. This is just a sample image of what thermography looks like, and this is ideally what it would look like if you were to detect a breast cancer. You have increased heat over the tumor. Clinics out there are making claims that thermography can detect breast cancer 8 to 10 years before it's identifiable on mammography, and there's just a lot of concern of sort of false information out there for patients. Molecular breast imaging is done with sestimibby. It's approved but not in wide use. Initial studies used relatively high radiation techniques, so it never really came into popular use. But there are newer low-dose techniques which improve the risk-benefit profile. And again, this is intended for use as a problem-solving tool, but it could detect up to 8.8 additional cancers per 1,000 women screened. So this is just an example, again showing an extremely dense breast and an area of sestimibby uptake in a small cancer. Proteomics is another area in development. The holy grail essentially is to identify a reliable serum biomarker for screening, treatment, and surveillance, but unfortunately we haven't found anything yet. So what to make of all of this? I mean, there is more evidence related to screening for breast cancer than any other cancer, but most of the topics related to screening are still controversial. So the questions of who to screen, how often to screen, when to start, and when to stop, there's still a lack of clarity. What is the true mortality benefit of screening, given that these changes in screening technology and other treatment methods have developed since the landmark trials that we're basing our screening recommendations on? What do we do about the issues of false positives and overdiagnosis? How do we make sure that women are educated as to both the harms and benefits of screening and the implications of recall from a screening test? And in this case, actually, what's really come into vogue in the journals lately is shared decision making. So it's important to make sure that women are educated as to the harms and benefits of screening, and because different women will weigh these factors differently. And it's been shown that in the States in particular, although 96% of women said that their healthcare provider discussed the benefits of screening, only 20% had the potential harms discussed with them. There's a lot of decision aids available, and these have been shown to improve patient knowledge and to reduce their conflict about making a decision. And actually in Australia, they did a randomized control trial of how these decision aids affected patient decision making. They actually included information on overdiagnosis. And they found women had much less positive attitudes about screening and decreased intention to pursue future screening. Now, is that a good thing or a bad thing? It's hard to say. This is just an example of that guide, which I thought was it's nice and clear. Shows sort of the likely outcomes for patients based on, a large screening population fairly effectively. And it very clearly explains overdetection. So the other question is, how best do we stratify screening for patients who are at increased risk of breast cancer? Given the very large number of women who are at increased risk due to dense breasts, the question of how best to address this population without overburdening the system and increasing the harms related to overdiagnosis is really tricky to answer. I think that despite the American legislation currently regarding dense breasts, we really lack the evidence to recommend adjunct screening solely based on increased breast density. There's a lot of promising options for additional screening out there, but we really need more research before we start adding that cost to the system. I think the most important thing is just to maintain radiologist awareness of decreased sensitivity in mammographic screening and to make sure that recommendations are made appropriately. We need to focus on appropriate workup of suspected abnormalities, and that should be done in a way that decreases costs to the system and patient harm that results from false positive screening. There's limited morbidity from recalling patients for additional imaging if we're able to provide timely reassurance. And I would say that of the modalities not currently in use in Manitoba for diagnostic workup, Tomo has the best specificity in women with dense breasts. It's an excellent adjunct in decision making. It leads to less unnecessary biopsies, and it can be performed concurrently with the additional mammographic views used in diagnostics mammo. So I think my biggest takeaway is that I was really impressed with the reduction in false positives with Tomo. And I think ideally it would be good if this was available along with targeted ultrasound in patients recalled for abnormal screening examinations, particularly patients with dense breasts. I think it would be a cost-effective option for confidently ruling out significant abnormalities, particularly in these patients. And although this equipment is currently available in Manitoba, it's unfortunate that the funding and resources for data management and training are not currently available. I was then sort of interested, this was all screening, but how good is Tomo in the diagnostic setting? There's some evidence for use in that setting, and it shows increased sensitivity and a non-significant trend towards increased specificity in the workup of patients with suspected cancers. And it's actually been fairly dramatic, the results. There was a case, one trial actually found that in women with clinically suspected abnormalities, a lot of which were palpable, among the 129 cancers that were diagnosed, 48 of them were seen on Tomo, but were not seen on mammography. Tomo also permits superior BI-RADS categorization. So is this, something that requires further workup? Is this a 3, a 4, a 5? Radiologists were more confident and showed better concordance between their assessments when Tomo was incorporated. The only thing is that it's unfortunately unclear whether there is an additive benefit when you also include ultrasound in workup. So we've gone through the background of breast cancer screening. We've looked at the evidence for supplemental screening in women with dense breasts, which is limited. We've looked at the supplemental screening modalities available, ultrasound, which is not cost effective, MRI, which lacks a lot of evidence and is extremely expensive, and Tomo, which is promising, but more work is needed for screening at least. And we've talked a little bit about how we might apply this. So these are some of my references. I think this was a very good paper. If anyone's interested in this topic, would be sort of the one to have a look at. And then, of course, there are many, many others, but we won't get into that. So thank you very much for your attention. If anyone has any questions, I'd be happy to take them. Otherwise, thank you.
Nice job, Signy. What was the reduction in callback rate with Tomo?
So,
Two studies, right?
yeah, so those were both using it in a screening setting. And oh yes, okay. So the question was just what were the reductions in callbacks with Tomo? And there were 2 studies that looked, well, there was more than 2 studies, but there was one conglomerate of 3 studies that found one result, and then there was one trial which found a different result. So in screening with Tomo, there was one trial that found that there was we went from about 4% to 5% for recall, which is still fairly low. And that trial was one where there was going to be increased likelihood to recall because they were double read, and if either radiologist wanted to recall the patient, they came back. Then there were 3 trials which looked at basically only a single radiologist read and made the decision, and all 3 of those found that there was a decrease in callbacks of as many as, I think it was up to 16 per 1,000. Let's see. It is, in the sense that the test identified an abnormality which was not ultimately the abnormality that the screening test is intended to detect, but it's a fairly low morbidity false positive. Let me just double check the number there. So it was, yeah, so 16 per 1,000. So about a 1.6 reduction absolute value in callbacks. Oh, hello. Sorry, is there a question at HSC? Oh.
What's that QALY? Can you explain that?
Oh, yes. So some of the papers that I looked at absolute reduction in, absolute improvements in how many life years could be gained, but others used quality adjusted life years. So if patients were unwell as a result of the treatment for their breast cancer, that was considered to have less value as an additional year than someone who had no reduction in quality of life related to treatment.
That's pretty subjective.
It is, and that's why I mean it's good in theory, because simply being alive is not necessarily the only outcome you want to assess. But at the same time, there's different methods by which people do that quality adjustment, and you need to kind of take it with a grain of salt with every paper and look at how they made that adjustment.
What were the numbers? It ranged like from 20,000 to 200,000?
For years of life gained with screening, or?
Yeah, it seemed to be used a couple times.
Yeah, well, I think a lot of the variability has less to do with how they're adjusting life years gained for quality, and more to do with the fact that different studies with different populations just had different results. Oh, do we have a question at HSC, or?
I've got a question.
Okay, hi.
Signy,
Hello.
just a fantastic review of a very controversial subject. You should be proud of yourself. I know that this is, I was involved in the CAR guidelines when we drew up our guidelines, and we were recommending screening starting at 40, and I know a lot of the criticism from the radiology community is that the task forces used randomized control trials which used very old equipment, and they argued that current equipment is much more effective and much more specific. But I think you sort of talked about that. I have a couple of questions. One is the issue that the task forces don't recommend breast self-examination because there's no good evidence of, well, poor specificity. Now, my concern has always been about that is that we are trying to encourage patients to become more involved in their own health care. And it seems to me that there are certainly risks to self-examination, but suggesting that it's not useful to women may be not a good idea because it sort of discourages them from being involved in their own health care. And I certainly know of women who have found tumors based on breast self-examination. So I wanted you to comment on that.
For sure. So I think it's an interesting question that I've heard a few people raise, especially people who've been involved in guidelines sort of in the past and seeing them change now. I think the issues that arise are essentially, is lack of evidence for mortality benefit the same as evidence against a mortality benefit? And the other thing is the issue just the specifics of how we were telling women to specifically examine, here's the exact technique you should be using, et cetera. And what do we really mean by this more amorphous breast self-awareness term? Does that include, what does that really include, and how can we best educate women to make sure that they are maintaining breast self-awareness, whatever that is? So I wouldn't be surprised if we see sort of a soft reversal in this recommendation at some point, with maybe a little bit more specifically about what aspects of breast self-awareness women should be educated about, what breast self-examination could include for them, and what things they should be most concerned about at that time. I think a lot of the false positives that came from breast self-examination was that women were being educated about how to check their breasts, but they were not really being told much about what are normal variations in breast composition, how are they going to change throughout your menstrual cycle, things like that. So if people identified any lump, any area of tenderness, they wanted to be conscientious, they wanted to get it checked out, and you go to your healthcare provider. And I think maybe there needs to be a better combination of education about normal and how best to identify what's abnormal.
Okay, thanks. And one other question. I think there's some suggestion that very small tumors, DCIS that's picked up by mammography, particularly more advanced mammography, may never progress to a significant tumor.
Yeah.
And that's one of the problems with screening.
And that's the issue of overdiagnosis, yeah. And as we're finding, there's more and more evidence that this is a much larger issue than we originally anticipated when we were looking at the results of those original screening trials.
Thank you.
Thank you. All right, well, that's all. Thank you, everyone. Have lovely afternoons.